was going to start and was not.
Carla is trying to get in because
Um,
room was showing full. Carla, ¿puedes entrar?
Yeah.
okay, you are in.
Do we give extra points for people looking more formal with a tie and jacket, or for people with T-shirts looking?
That's up to the judges. That's part of the game. That's point number 4.
I think Stavros and I look so relaxed. So Piano looks like a wonderful Italian young man.
Well, for Star Wars is already bedtime. Okay, Carla, finally.
Hello.
Nice to see you. Okay, so
Hello.
everybody is aboard. So I think we can go live, Katalin. Are we live?
Yes.
We are.
Yes, we are.
Okay, so good evening, everybody, and welcome to this international challenge. We are very happy to host this event, and we have the first game tonight will be between Germany and Spain. It's a big game, like in football, in soccer. So we are very pleased to have 3 international judges that are Gianno Ricci, Dave Winkler, and Stavros Pelekanos, 2 past presidents of the European Academy of Aesthetic Dentistry. So very, very, very tough judges tonight for you guys, but I'm sure that you will be very, very good. As I said, you are already winners, and I just want to renew the rules of the game for the people watching. We will have 4 presentations, 2 from each side, lasting 15 minutes. Time will be very important because every participant has 15 minutes of time to deliver the presentation. And 3 judges are recording the scores, and they will judge according to different parameters: the quality of the presentation, the rationale of treatment, the
Rational.
sorry, just a second. Somebody's trying to call me. Okay. Sorry, so we have different categories, and the point will go from 0 to 5. 0, which is insufficient, to 5, that is excellent. The judges are not going to vote until the end of... why the host muted my microphone? Can you hear me? Sorry. Is it okay? All right. So the judges will vote until the end, so that we'll have some suspense. And also the judges, at the end of the presentation, will have 5 minutes to interview the participant. So I hope this will be a fun and entertaining event. And now we let Carla choose head or tail. We have a coin with the head of Queen Elizabeth, which is international, and 2. So we will toss the coin, and you decide if you want head or tail. Carla, your pick. Your microphone is off. I think either you or the director put you off.
Okay, let's go for head.
Okay. And it was tail, unfortunately.
Okay.
So the Germans will decide, and they have the option to go first or let you guys go first. So who's the team captain for Germany? Christian or Paul?
Yeah, I'm
Okay.
the captain. We said ladies first. Carla,
Okay.
Spain.
So
Okay,
Carla
thank you
will
so
be the
much.
first, and who will be the challenger of Carla? Will be you or Paul?
That's Paul.
Okay, so Carla, it is your turn. You will have 15 minutes starting when the screen, when you share your screen and you give your presentation. Again, I remind the judges to make notes so they will be able to give their votes at the end of all 4 presentations. Good luck to everybody and have fun. I hope this will be an enjoyable evening.
Thank you so much. I'm sharing the screen. I don't know if you see my presentation.
Yes.
Okay. So first of all, thank you so much. Well, I'm Carla Vidal. I'm from the university, from the Universidad Internacional de Cataluña. And first of all, I wanted to thank the organizers for this CEPES IFED challenge. Today, I'm going to present a rehabilitation case. Patient that came to the clinic with a chief complaint of yellowish discoloration and poor appearance of his teeth. And after collecting all the information and studying the case, we observed enamel lesions covering all the surfaces and no symptoms presented. So in intraoral examination, in a close-up view, there is a reduced amount of enamel with roof surfaces with some space in between teeth. And also in this view, we can observe an asymmetry in the gingival architecture between the first and the second quadrants. And based on clinical and radiological examination, according to Roman and co-authors, it was diagnosed as hypoplastic type of amelogenesis imperfecta, which is characterized principally by a reduction in the thickness of the enamel matrix with a normal mineralization. So radiographically, we saw that the molars were previously restored without the presence of any apical image. So to carry out the case study, as for any type of interdisciplinary therapy, we need photographs for the smile design with and without the tractors. Initially, records that in this case we took an intraoral scanning, and CBCT for the case planning. At this point, once we collect all the data, we start the file integration to make the smile design using the upper central incisor as a reference. The CBCT was aligned to the WhatsApp, so we could make a perioprosto planning according to the aesthetic requirements of the case. And this CBCT was performed with a soft tissue retractor to allow us to visualize the gingiva separating the lips, to achieve some information such as the distance from the gingival margin to the CEJ, which in this case was increased. The design was clinically tested through a mock-up with bisacrylic resin. And here, an external view where you can see how the patient's smile frame changes due to the soft tissue adaptation, probably because of the confidence that the patient acquires in this phase. So we made the necessary modifications and we scanned the mock-up to transfer the information to the digital design. So the treatment plan proposed for the patient was to keep the restorations in the molars that maintain the vertical dimension and to make indirect adhesive restoration from premolar to premolar in both arches. The type of restoration and the extension of the preparation were selected according to the amount of sound enamel present. So first of all, based on this validated design, we fabricated a surgical guide to make a gingivectomy in order to harmonize the gingival margins between both quadrants. Intrasurgical scans were performed to verify that we were following the planned design. So for that, using the comparison analysis software, we aligned our post-surgical scan with the WhatsApp design to verify that no further modification was necessary. So in order to provide soft tissue stability, we provisionalized the patient with this acrylic material, providing a polishing protocol using red and yellow flame bars to avoid inflammation. After 6 months waiting for the tissue stabilization and occlusal adaptation of the interim prosthesis, we started with the restorative sequence. And in order to be minimally invasive, the preparation was performed through a mock-up according to Galip Gurel. And prior to taking the upper impressions, and immediate dentin sealing was performed using a 3-step adhesive, the Optimon FL. So the tooth preparations basically followed a crown design, but on the palatal side, we tried to find sound enamel, being as much conservative as possible. So once scanned, we sent to the lab the STLs, and we checked the final design adapt to the preparations. The material selected in this case was IMAX press, so the crowns were monolithic with micro layering from canine to canine in order to achieve translucency in the incisal third. And we perform a try-in to evaluate the marginal fit and the contact points of the restorations that we prepared following the adhesive protocol for lithium disilicate according to the authors, applying 5% of hydrofluoric acid for 20 seconds and following the surface cleaning protocol. And for the teeth, since previous IDS was performed, we sandblasted using aluminum oxide 50 micron, and we performed the cementation protocol using a universal adhesive with a light curing cement. Here you can see different views of the final result and the before and after of the upper arch. Once it was completed, we started with the lower arch, in which the preparation performed in this case was a little bit more conservative, thanks to the presence of enamel. And in this case, the restorations were monolithic MX press, stained from premolar to premolar without layering. And we followed the same adhesive protocol as previously mentioned in the upper arch. Here, a frontal and occlusal view just cemented, and a follow-up after 1 year with an intraoral and extraoral view of the patient. And the before and after, where you can appreciate the muscular adaptation of the patient, who has changed his lip dynamics, and there is no longer an asymmetrical upper lip. We always like to take pictures of the result with different flashes, especially a picture without diffusers, and a polarized picture to evaluate the color between arches. And according to the American College of Prosthodontists, following the post-rehabilitation recommendations, we provide the patient a meal night guard to protect the restorations. So, in conclusion, we can remark that it's not common to treat this type of lesions in our daily practice. Therefore, it's needed to be updated about how to approach the treatment. The second is that the type of the preparation due to the defect in the enamel should be covered as much as possible following an adhesive protocol. And finally, approaching this case is digitally help us to control every detail of each step, and principally to replicate the result from the planning stage. So that's it. Thank you all for your attention, and I think
Well, congratulations, Carla. That's a hell of a start. Beautiful case, beautiful documentation. And I'm very sure that the judges will have a difficult time, but you scored already your +10 because you fit perfectly within the time. So we give
Nice.
the screen and the word to Paul. Please, the director can put Paul on the screen so that he can deliver his presentation.
Don't allow. I think I leave the.
Okay, good luck, Paul.
You. So could you see my screen? Okay, I think my screen, so I can start. It was an amazing start from Carla, and so I would like to go as the first one for the team Germany, and we are 3, and so these guys are with me. So we started to go for a topic which is a little bit controversial, and we like to discuss it afterwards with the judges and so on. The first topic is no buckle bone. So we go for a little case. So I will show a single case, and afterwards we go for a more complex case, and Christian will show us no traditional author. So this is the intro, and we would like to start with the first one. So the first one is no buckle bone, and I would like to give you a short.
Paul, sorry,
Yep.
we cannot see your screen. So wait a second, because without the screen, we cannot win. There's a technical problem. So just give it a second so that we can see you. Otherwise, we see your face, but we don't see your presentation.
Oh, that's not nice.
Probably is Carla connected. Yeah. Don't worry, I will start the time only when the slides are starting. So
Okay.
no problem with that. Katalin, can you take care of this?
Can you see now the presentation?
You have to share the screen. I think you are not sharing the screen at the moment.
You don't see?
No.
Okay. Share. Now?
No, I still cannot see.
Okay. Share.
Katalin, what can we do about this?
Sharing the window. So
You can put me away, Katalin. Just leave the guys.
okay. Still you did not see the screen.
Okay.
Now
Now
it's
we
in
can see your
presentation.
screen. Perfect. Go ahead.
Oh, perfect. Okay, we start again. Sorry for that interruption. Now I would like to give a short introduction to the team Germany. So we are 3, and I have these 2 amazing guys next to me. So we would like to go for a controversial topic, and this topic is called no, and no for no buckle bone. That's the first topic. So I go for a case with no buckle bone, and afterwards Christian goes for no traditional ortho case, so a more complex case. So you will see both in these 2 presentations. So just to give a short introduction, I would give you a short introduction when we go for immediate implant placement. So it's very important to have literature about this topic. So we have a lot of literature and a systematic review. It's from 2022, and it shows the same outcome even in bleeding, bone stability, and tissue stability. So the most important thing when we go for immediate or delayed loading, it is the most important thing that we reach primary stability. So that's the most key factor to be successful in these cases. And the other one is when we go for immediate implant placement into an infected socket. So every one of us has a bad feeling in the stomach. So, but there's a literature out there. We have a systematic review, and there's even no difference in non-infected or infected sockets when we go immediately into it. The only thing is we have a slightly difference when we go for keratinized tissue. So when these 2 things are good, so we can go for the next one, and the next one is a compromised socket. When we have a socket where is something missing, so when we have missing buccal bone or something like that. So we have not as much literature to go for immediate implant placement in a case like this, but we have some systematic reviews to see there could be a good treatment. So let's go for the material and the method. The first thing is time. When we have a single tooth which is going has to go out. So when we go for an extraction and we have in compromised sockets, the normal thing to go for an aesthetic rehabilitation in this case is a case with 3 surgeries. We go for extraction, go for some bone augmentation, go for immediate or delayed implant placement. After that, soft tissue grafting and something like that. And the time of the treatment are mostly 1 year or sometimes more. So we did in cases with a compromised implant site, we called it the multi-layer technique to do everything in one shot. So we go for extraction, we go for immediate implant placement, we go for soft tissue augmentation, a hard tissue augmentation, and an immediate provisional restoration. So that is the goal for cases like this. And we published something in the Germans and now in the materials in 2021, and did in the group of Hannes Wachtel and myself nearly 100 cases in the last 8 years. In every case, the buccal bone was missing. So I will show you a clinical case for this kind of treatment, and we need to go in and need to see what's happening. So this young lady has crowns, and the 2-1 has a vertical fracture. So we go for a digitalization and we go for a digital transfer to see everything before we match the CBCT with the initial situation. We go for wax up and match the wax up also to the CBCT to see what's there and what we have with the bone. Here you can see in the middle one there is apical lesion and no buccal bone. We can measure everything perfectly nowadays. So this is what we can do before and can go for planning for a treatment plan, what we want to do. Here's the CBCT match with the wax up. So we can see we have an apical infection, we have an endodontic treated tooth with an apical lesion and no buccal bone because of the vertical fraction. So this is the clinical situation. We all know that when we go in, when the probe goes deep in, we know there's no bone outside there. We go for a planning, and the planning is with AI, so we can see how is the bone and can get planned for the drilling guides. So this is everything very nice, but the most important thing is to feel the bone and the tissues and everything around there. But we can use the digital workflows and the guides to be better and more precise to go for the immediate implant placement. So we can prepare everything before, and we can do these things in our own lab. We go for a printed sleeveless guide. This is the first thing. And after that, we did the provisional, always prefabricated, so we can see how precise we are when we go for the extraction and the immediate implant placement, and go for immediate provisionalization in this case. The first thing is to extract the tooth. It's a long one, you can see it here. So we need a longer implant for this case. We go for the drilling sequences. You can see it like here, and after this we go for immediate implant placement. We need a primary stability. I try to reach 30 Newton centimeters to go for stability, to go for immediate provisionalization. And I go in every case with an abutment. It's the octa abutment. It's an abutment one time, like Stavros described it in 2017. We try to go for one abutment one time and try to screw afterwards in the tissue level. So it is smaller than a multi-unit abutment, and we have different brands out there. They have these abutments in stock. So this one is very nice. So we go for the abutment to bring it in. After that, we go for a tunneling technique to go for soft tissue grafting. So we use a graft from the tuberosity and bring that in with a microsurgical approach for sure. And this one is the buccal plate. Is a bony buccal plate from Italian porks. It's from Osteobiol. It is the soft lamina, bone soft lamina called. It's completely resorbable, and you can put these into a full flap into your socket and rebuild your buccal bone with the same procedure in this case. So bring that carefully in. You have to be very careful because of the papillas, and it has to be everything flapless. And after that, you go for the last thing, and the last thing is the immediate provisionalization. So this is everything prefabricated, and we were very near to the final outcome. You can see this was not perfectly executed, but we were very, very near to the final one. So the provisional goes back to the lab, and we made some composite to fix the gap. And this one is 3 months after. Here you can see the X-ray with the octa abutment on top and the provisional, and this is the occlusal flue. So we overbuilt the socket or the implant bed, so we can go for final restoration. And this is where digital meets the analog way, because we go for every case to splint our scan bodies to the teeth next to it, because so every dental technician has a passive fit reference to check if the digital workflow, when he went or she went to the analog way and go for printed models and something like that, he can check if that's perfectly way and everything fits perfectly in this way. So after that, the final crown was delivered. So this is one of my favorite treatments, because the provisional goes out and the final crown goes in. So this is very, very easy. You can see it, everything is quite stable. This one goes in, and it looks like this. This is after 6 months, and we can see it after 12 months. The prosto looks quite nice. So the conclusion, we made a study and its follow-up around 5 years, and we had amazing results in the static area when we go for this technique, even when we have a buccal bone missing. So thank you very much. I hope I'm already in time, and sorry for the technical issues at the beginning.
Thank you very much, Paul. Beautiful work. I know your work very well, so congratulations. And you also got your 10 points bonus because you finished in 12 minutes and 24 seconds. So congratulations for this. And now is the turn of your teammate, Christian. Christian, get online, and you get to start now this time. Good luck.
Okay, thank you. I'm trying to share the screen. Am I able? I need the right to share it. Wait. Standing, I'm unable to share the screen. I hope it works. Could you please give me a short information if it works, Roberto?
While and then disappeared.
Now it works?
No, not yet.
Okay. I think Ulpia has to give me the rights. I'm unable to share the screen. It's not allowed.
Maybe Paul is still, is he out already? You cannot share the screen?
Oh,
Katalin, can you please check what could be wrong? You have to push the third button.
I know.
None? Okay, now we saw something. You
No.
disappeared and we saw
No,
the screen for a second.
I checked the camera if this works, but it doesn't. I'm not able to share the screen. In the test it worked, but now it doesn't.
It's the same problem as before.
Mm.
Oh, somebody's saying the Spanish have sabotaged the German presentation, so we have a problem. So
Sorry, I'm not able to share.
okay, let's see if Alvaro can try to share while we are working on this. Alvaro, can you try to get online? I mean, can you put Alvaro in the screen, Catalin, please? And we see if we switch, if there is a miracle, and then the German will reconnect. Okay, now we see the big screen. And Alvaro, okay, Alvaro will go ahead of you. Sorry, so we will not waste time. Okay, Alvaro, are you online? I don't see you. Can you give the microphone to Alvaro and put him on the screen, Catalin? The microphone of Alvaro is off. Can you please, Catalin, give him, put his microphone on and put him online? I cannot hear you. No. So we have Christian that has the video and we can hear him, but we can see the video of Alvaro and we cannot see him. And the direction, well, okay, now we can see for a second the presentation of Alvaro. Okay. Try to get out for a second and re-enter. I guess that's the only way we can do it. Okay, maybe we can, while we have this lag time, we can get one of the judges to give a brief impression of what was the first match. Can we get one of the judges online? We cannot get anybody online. Can we do anything about it? Catalin? Okay, Dave is online, but we cannot hear you.
No, the host has to
We
unmute.
can see you, okay. No, so the thing are working, and so far I think the presentation are beautiful. So I think you will have a difficult time in handling these votes, but we should not be unfair. We just say everything so far is very, very high standard. The quality is excellent, and everything is fine. Katalin, why can't we hear you? I mean, can you just put back Alvaro on the stage and his presentation? Okay, now I see Alvaro.
Okay, can you hear me?
I can see you. I can hear you. Wonderful.
Perfect.
Okay, let's try. We can see if you can share your presentation as well.
Okay, this is 10 minutes, right? Presentation
15
time?
minutes. Yeah, 15 minutes. So
15.
you can relax and a little more time. Yes.
Can you see my presentation?
Yes, we can see your screen. You
And
can
you
go
can
ahead.
see me and hear me?
Yes, we can see.
Perfect. So thank you for the kind invitation. I'm very excited to be here with you all, and I hope all the good luck to all the other players. So I'm going to present to you interdisciplinary team approach of one case selected, and I'm here on behalf of my team that is between orthodontist, periodontist, restorative dentist, and endodontist, and that I'm just representing them in the way we work in the clinic. So I want to present to you a patient that came to see us in 2012, and this patient had fluorosis in some of her teeth, all restoration on tooth number 21, and also gummy smile. And as we see the pictures, especially extraoral pictures, we are starting to think that it's going to be challenging situation to treat if her chief complaint is she doesn't like the old restoration, she doesn't like the way her teeth look, the shape of her teeth, the shade of her teeth, and the gummy smile either. But she has a very tough also functional issue, and she's not able to chew. She's not able to chew because she had a cancer, carcinoma on the mandible, and they resected her mandible and reconnected again with a fibula graft, and had long-term healing of this and canting of the maxilla with super eruption. So we can see this extreme situation, and the only way to be able to treat this patient and give her regular life would be if we work within a team of specialists. But let's go together and analyze this patient. Because we see this patient has gummy smile, that's one of her chief complaints. And we know from Robbins, Bill Robbins, that he published his book, that there are 6 options that this patient may have gummy smile. Because depending on the diagnosis, what is causing this gummy smile, the treatment is going to be very different. And we'll divide this for you as a E of extraoral and I as an intraoral, and then a combination. We can have a vertical maxillary access. They can have a maxillary lip that can be short or normal but hypermobile. We can have intraorally now outer passive eruption or compensatory eruption due to, for example, this patient that had no mandibular teeth. And also it can be a combination of several of them. So in this patient, we have a combination of vertical maxillary access that it can be misleading of the extraoral picture because she doesn't have, like the mandible is being distorted, but it actually has vertical maxillary access. The maxillary lip is hypermobile, and due to not having mandibular teeth, he has a compensatory eruption or extrusion of the maxillary teeth. And because it's very difficult and very challenging case, we like to divide the problem in problem list. We can see that the mandibular ramus are wrongly connected because this first treatment before coming to see us was done by an ENT, and the ENT did a fibula graft from the leg and tried to connect the ramuses, approximating the extension or the edges to be less morbidity on removing the fibula graft. But then what happened was that he dislocate or remove the condyle from centric relation, and also create a deficient intermaxillary space for any prosthesis that we could give to the patient. We have a deficient mandibular bone height. We have mandibular soft tissue that is skin from the leg, extrusion and maxillary canting. We have also, the patient has recession on the first upper right premolar, and she demands not only function but also aesthetics from 15 to 25, second premolar to second premolar. That's what she shows when she smiles. As a treatment list, we're going to be performing connective tissue graft on 14, new crown on 21, ortho intrusion of the maxilla, restorations, this time 16 to 26, because we have to do a combination of ortho, perio, maxillofacial, and pros to be able to solve this issue. And on the mandible, we'll be removing the surgical plates, vertical bone graft, and full arch rehabilitation for the mandible. So it's not only the treatment plan, but the treatment sequence. As Jaime Hill always says, that if you don't know where you're going, you will never get lost. So it's very important that you define your treatment goals before you begin treatment, and to create your treatment sequence that best fits your patient. So the options that we have are, we can reconnect the base and the ramus to bring condyles to centric relation and increase the maxillomandibular space for the prosthesis, but that's very challenging. We can make a maxillary impaction because this patient has vertical maxillary access, so we will be solving not only the aesthetic issue that the patient has, but also the problem with the space for the prosthesis. We can also do short implants on the mandible, or we can do intrusion of the maxilla, regeneration, and implants. So if we think about number 4 as an ideal treatment for her in this challenging situation, would be intrusion, then regeneration vertically. But what's the problem here? If we regenerate this bone on the mandible, we're going to get great vertical bone, or we could get great vertical bone for the implants, but we're going to be getting worse or making worse one of our problems, that is the prosthetic space for our prosthesis and the materials that we're going to do for a fixed restoration on the mandible. So we, yes, are going to regenerate, but the only way to regenerate vertically is going down to create this height for those implants to be placed and be able to change the patient's life, giving her a fixed prosthesis on the mandible. So we can see here, we did a combination with the maxillofacial surgeon. We did a vertical bone graft on the mandible. We reopened what the ENT opened before to remove or resect the mandible. We reopen the same axis and regenerate the mandible and get that height. We also locate mini plates on the posterior to be able to intrude the posterior, and we will see how we place mini implants on the anterior area to intrude the whole maxilla. We use what we call the PGO concept, that's prosthetically guided orthodontic concept that we published last year. We do a CAD-CAM restoration. We mirror image the 11 in 21. We use the same shape that the contralateral side, and the position should follow the root long axis. We are not modifying, or we are not improving any position with our restoration. We want to have mild position tooth, so we can position well the restoration and the root with orthodontics that can be fixed appliances or aligners nowadays. We also have this POIP concept that we place implants before ortho, but in very challenging situations like this situation, we don't do the POIP concept. We do the MIOIP concept, which is medium ortho implant placement, because we want to have the ortho movement up to 75% of the final position. Then we place the implants and we do provisional restorations on those implants to use them as an anchorage and also as a reference for function and aesthetics before we finish orthodontic therapy. And we can see here the intraoral view with the mini implants on the anterior to be able to intrude the whole maxilla. We don't want to have a relative intrusion when we have a proclination or extrusion of the posterior segment. We want to have a pure intrusion, and we use for this case, mini implants or many implants in the anterior area and mini planes in the posterior area. And we can see here the summary. We also did a tunneling technique on the first premolar for the recession, and we can see here the mini plates, and I already placed the implants on the mandible. And we can see here that the mini plate on the right is not well located. We made a mistake. We didn't place them too deep, and that is going to create a problem down the road that we can see together as we go through see the case. And what we do is we like to print the maxilla to have preformed the mini plates, so with the intrasurgical time is less. And we published this recently this year, how we use the printed maxilla to have this preform before surgery. Once the implants are integrated, and we can go ahead and take an impression. If we're going to generate a model, we like to use the verification jig. We like to do it in stone, and we also describe this step by step how to do it and why to use this material instead of acrylic. So if it breaks, your master cast is not as it is in the mouth, so you have to retake the impression. Once we have that, we can generate the provisional PMMA, and we know from Pradis et al. That it is not only challenging in the scanning, but also it's very challenging on how we generate the models nowadays printed, and it's very challenging how we generate those models. So it's a lot of distortions and things to get into considerations while we're doing full arch implant rehabilitation. But yes, for sure, we want to make sure that in our design, the CAD-CAM, in the thickness of the material, we have 2 millimeters at least in the screw channel, so there is no breakage while giving torque to this rehabilitation. So we can see here, and we apply the concept of CPR from Riccardo Mitrani, and we now know that we can restore the maxilla. We keep the mandible in provisional because it's not a regular case. We want to make sure that every step is taken into consideration to make sure that patient is comfortable, there is no discomfort, and we give this patient a groove function. And we have here, see the maxilla of lithium disilicate with the mandible in provisional. And we can see the occlusal view, how we, because we didn't locate the mini plate on the upper right deep enough, we were not able to intrude as much as we needed. So we had to prep on the 16 and 15 to compensate that limitation of the orthodontic movement. But on the left, we were just have to define the line and have that bonded on this upper teeth. Once we analyze the mandible and we know if the patient bruxes or it doesn't brux, or how much strength we need, for this case, we use this classification that we want to have, for this case, full lingual support with zirconia, and we just layer the facial of the area, and we leave all the functional areas in full zirconia. We can see here we optimize the maxillary teeth position, we increase the restorative space, we plan and place mandibular implants, then we have the mandibular provisional, we test drive, then we finish ortho, we finish the upper restorations, and we give the final prosthesis on the mandible with zirconia, so we can see lithium disilicate on the maxilla, and zirconia with layer ceramics on the facial on the mandibular, and this work done by Aram Torosian. And we can see here the CBCT and this challenging situation, which yes, some risky to place those implants, but at least everything is holding well. And we can see here what we started in 2012 and we finished in 2015, involving the whole team to make sure that everyone was doing their job to be able to change this patient's life, not only aesthetically, but functionally, and she's able to chew properly and do regular life nowadays. As a conclusions, in a teamwork approach, we have to accept individual responsibilities and frequent meetings and create systems within the team. We should be patient-oriented and comprehensive consultation, and we have to learn to listen to our patients. And ortho is not always in the game, but if it is, we have to have occlusal and aesthetic diagnosis and periodontal diagnosis before starting orthodontic therapy. And during treatment, we have to verify guides, printed the models if possible to verify everything, and have ortho perio resto communication or prosto communications. So thank you very much for your kind attention, and looking forward to the last presentation.
Alvaro, congratulations. Wonderful case, very complex and handled very, very well. I'm sure the judges will be impressed, and they will have also some questions for sure, because this was really, really nice. Congratulations. So, Christian, I hope everything is working this time for you, and good luck.
I hope everything works now. Let me share my screen. Oh, perfect. That's fine. It looks nice. So thank you for the invitation for our team Germany to have this today and this evening. And I'm sorry for the technical issues that we had, but that's life. So in our case that we did here, the topic is no traditional ortho. So the DNA of aesthetic dentistry, what means to produce a captivating smile, is that we have always to need for treatment protocol, and treatment planning is so much more than only to know what to do. It's about data assessment, diagnostics, the risk analysis, and the prognosis, and it's all about making the right decisions for your patients, for you, and it's all about doing the backward planning. So what we have is an overview here where we go in through every case, through dental facial, to functional, to biomechanical and periodontal. In this patient, you see a young lady who has a lot of problems here. She came to my office for a second opinion, and her problem list is that she had an anterior open bite, that there are a lot of crowded teeth with a negative Krontag. You see in the between the incisal that there is the early beginning of the black triangles, and we have hanging posterior corridors, and there is a thin biotype with early recessions. So what we see when we see it extra early, that the problem list intra-early is not only enough. You see a lot of things more. You see a gummy smile, you see a high lip mobility, you see asymmetric arch forms, not competent lip closure, and a very young age with thin biotypes and the early beginning of the recessions. So in the point of view or through the lens of an ortho specialist, we should think about thinking of treating her through the lens of a generalist, because this is a multifactorial problem here. And so the first thing is what we always have to consider is, where are the teeth in the face? So dentofacial is crucial. Then going through function and having biomechanics and perio. And that's where we come from. We have the facial generated treatment planning, where we go into the dentofacial, the aesthetic, the function, the biomechanics, and the perio. But now we are in the facial and airway generated treatment planning. So we know now that airway is much more important than anything else. So this is the protocol, even for prosto and ortho, where we go step by step through every case, have a nice problem list, and then could consider what we want to treat and what not. So what about the airway in this case? Structure is a high palate and narrow arch with 35 millimeters, which should be 38 to 40. The function is an anterior tongue thrust and with a posterior tongue tie. And her behavior was that she was knowing about that, and she already did some myofunctional training in that moment when she came to our office. And we have nice devices to even show how much airway she has, where the teeth are. And the most common thing in our aesthetic planning is where to place the teeth in the face. So that's the dentofacial planning. So what we have is a risk protocol, and it's all about treating having a risk management and having a lower risk in the end and a higher and better prognosis for the patient in the long term in the end. So what I was talking to the patient is, when we look at the extraoral photos, is where should we plan to place the teeth in the face? So I made a short mock-up for her digitally, where I said, okay, to close the open bite, it is not good to only work with front teeth. We have to work with the whole thing and make it bring the teeth in the right position. So the problem is extraorally, we know already, and we have so good software to plan it digitally, digital smile design, smile cloud, smile fee, everything works, but we have to know what, where, and how. So this is now the gummy smile, what she has, and what we know is that there are 4 types what we can have, which are already combined. So first is the altered passive eruption, which is not a case in a situation. Then we could have some dental alveolar extrusion, the lip length and the dynamic, which is a problem for her, and the VME. So in her case, we see that lip length and dynamic is the problem and the VME. But the patient doesn't want to have orthognathic surgery. And so what's next in this moment? We can have the whole procedure here for the planning. And what we know is from smile cloud analysis where we have to place the teeth in the face. So we know from the problem is that posteriors are hanging down, and we could exactly give the technician where we want to place the teeth in the future. So this is now the protocol for the treatment. And from a traditional way of orthodonts, this is a huge movement for molars, but we know that the PDL of the teeth have the ability to bring the remodeling to the bone and even to bring back teeth upwards. So we now know from the 2-dimensional analysis to come to a 3-dimensional analysis to exactly know where we have the influence in the face and the profile. So we have a normal Ceph analysis. We exactly have the analysis how we could affect the profile to the patient and how we could manage the lip support in that situation. And then we can come into the occlusion. So the most common thing is that we want to know when we bring posteriors up, then we close the bite. We want to work in centric relation, and we want exactly say to the technician where he has to place the teeth with orthodontic therapy. So we want to have this position, and we got a counterclockwise rotation from the mandible. And so this is now the biggest question in that case, where do we place the teeth? But we have new devices where we can easily bring that to the technician. It's called the digital function driven ortho design. So we have an initial STL, we have the 4-dimensional real motion tracking, we can do the centric relation remounting in the correct vertical oral dimension. We do a digital wax up and mock up for the future position of the teeth. And then we can have a reference to match it into the CBCT and to see where the bone is or not. And then we have a final ortho STL, which could be treated by the technician. So coming to the execution is that we have first the planning phase, then the aligner with TATs, then having the thin biotype and risk of recession, and we do a connective tissue graft with soft tissue thickening, and afterwards the retention protocol. So what we already saw is that these are the movements of the teeth. This was the planning, And these are the movements of the posterior teeth. So in this situation, every aligner company has no ability to bring in the mandible in the right way. So what they always plan is the bite jump, but this is not the right position. This is where it's necessary to have the real motion and to have rotation from the whole jaw into the right position. So what we see here is there are the movements again, and this is the way we did it. We put some tats. This is an easy way to do. And with the tats, we have a skeletal anchorage where we can place the elastics over the aligner and bring up the force. And we always have the full control with the aligner if they are fitting or not. So the treatment timeline was that we started in May 21, and so we saw a lot of huge results in between a short time. Even when the patient lost one tat, we placed a new one, and then we can see how the bite was closed with the right overjet, enough functional freeway or enough space for the functional movements. And so this was the final result after ortho in that case. And we saw that we have a perfectly aligned upper and lower jaw. We have even small recessions. And what we saw here is summation between in the panoramic view that we see that the whole intrusion of posterior teeth, when we look at the base of the maxilla, was perfectly done without any resorption of the roots, even from the Ceph. And for me, the future of digital ortho planning, even from the lens of a prosthodontic, is in that treatment protocol, where we first look at the airway, then having a view to structure, function, and behavior. And what we always treat is that with ortho, that's the structure. Then we have the dental-facial, where we plan from the face, exactly knowing where to place the teeth in the face. Then we go into the functional part, and we should think about the role of centric relation bite registration in orthodontic and prostotherapy by changing the oral vertical dimension. Then we have a lot of improvements into the biomechanics by having freeway for the function to bring in less risk for abstraction. And then we have the perio treatment at the end. That was the connective tissue graft and soft tissue thickening. And so this was the final treatment. And for me, ortho is the new superpower of the prosthodontist, and all prosthodontists should use that, because we should not treat teeth or mill teeth when they are in the wrong position or do more invasive treatments in that moment. So I want to say thank you for your attention, and thank you for having us. And great.
Well, thank you, Christian. That was really beautiful and impressive. And I don't want to be in the shoes of the judges that will now have to interview and judge you, because it's just a pity that one of the two teams will have to be eliminated at this stage. But this was also the fairness of the draw, and it happened like this, and we have to be respectful of the rules. So I would like to leave now you in the hands of the three judges that will have 5 minutes each to interview you before we will proceed with the voting and with celebrating the first winner of this game. So who wants to be the first judge to interview the kids?
I'm fine doing that. Can you hear me?
David.
Excellent.
Go ahead.
You okay, Stavros, Gianni? Good. Very different presentations from all four of you. Of course, congratulations. Very impressive work. Very different types of presentations of cases you showed, ranging from a single tooth implant to full mouth rehabs. Carla, if I can start with you, a simple question. I might have missed it. What was the diagnosis with that patient as far as the enamel defects were concerned? Carla?
Yeah.
Yeah.
Do you hear me?
Yeah.
Yes.
Yeah, the diagnosis of the case, it was an amelogenesis imperfecta.
Thank you.
It was the hypoplastic form.
Excellent. I didn't have that in the presentation, or I missed it. Why did you, for a case such as that, why did you use CBCT?
So we took, as for all the rehabilitations, also we take a CBCT in order to planify the case, and also this CBCT was used for the prosto period planification, as we had to make a gingivectomy. So we measured all the information. So we took the distance that we have to cut from the gingival margin to the CEJ.
Okay, I understand that. Just coming from Denmark, which is very conservative, you'd have to really explain why a CBCT would be taken instead of using other methods, but that's fair enough. Paul, single tooth implant. Where are you, Paul? There you are. Beautiful photos. Unfortunately, a couple of the slides in your presentation were in German, if I'm not mistaken, and don't understand German, but an excellent presentation. I think that you used a little bribery in your presentation. I know that happens in football. There's a little corruption. You used a reference from Stavros in your presentation. Was that to just to bribe the judge a little bit? Just curious. I think that has to go to VAR to look at that again. There was a slight asymmetry in the, I mean, a single central incisor is the most difficult work for us to deal with cosmetically. We all know that. And there was a little bit of asymmetry in the gingival margins in the final result. Was there any way that you could have corrected that? Paul?
Yeah, I didn't get the whole question because I think the connection was
Sorry.
lost.
The result was excellent. There was just a slight asymmetry in the gingival architecture between the two central incisors. Was there any way you could have corrected that? Still not getting it? Okay, well, let me go to Alvaro there a little bit with the full mouth rehab.
Yes.
A comment is, personally, I think cosmetics were the least of her problems at the end of the day, having gone through such a tragic type of diagnosis and treatment. You come from Barcelona, is that correct?
Yes.
Well, there was a time just not many years ago when La Liga was led by Barca. You lost Messi, unfortunately. But I think that it was, a phenomenal case to do. There's no doubt about it. You went with zirconia versus against Emax. Is that correct?
Yes, sir.
Why?
Why? Because lithium disilicate allow us to bond, and so forth. We are able to prep less the teeth, and we are able to be more conservative. Nowadays, with the APC concept, it's been research showing that you can partially bond zirconia, but we still feel more comfortable while we're bonding to use lithium disilicate on the maxilla over teeth. And the mandible, we use zirconia. We could have used metal ceramics or metal acrylic, but we thought that even though doing the interdisciplinary treatment, the space vertical is not that so we felt comfortable using zirconia in full length and just layer the facial aspect.
You wouldn't have suggested or considered using one of the hybrid CAD/CAM materials?
Yeah, I mean, we could have used it. This case was done several years ago. Nowadays, we could have used like Zera Smart or Lava Ultimate or other materials. But we also had a central incisor which was restored crown. So I don't feel really comfortable using for a full crown with dentin like hybrid ceramics in my practice.
I think I'm probably running out of time, Roberto. Christian, I just want to say to you, your take-home message was superb. I think we as prosthodontists and restorative people do not use ortho enough. And, we'd love to drill, fill, and bill at the end of the day. I think the work you did was wonderful. The digital planning was extremely impressive. And for a guy who's been doing dentistry for 40 plus years that didn't know how to turn a computer on, a lot of you had problems turning your computers on tonight. It was very, very impressive. It was a very sexy, sorry if I can use that term, but a very sexy keynote presentation or PowerPoint presentation. So congratulations with that. Yeah, am I done, Roberto?
Perfect.
Okay.
Sharp on time.
Thank you.
Okay.
Vamos.
Shall I
Okay.
comment?
Do you hear me?
Yep.
Yes.
Great. So, first of all, to answer to Dave, there is no other publication regarding one-time partial abutment. So, it was the only one that he could found.
Okay.
Anyway, but I gave him 1 plus point.
Okay.
So, going back to Carla. Carla, very nice presentation.
Thank you.
Just one question. Usually when we do like full mouth cases, we elaborate a little bit about the overbite and the overjet at the beginning of the case. I didn't see if you used the CR position in this case because you did first the upper and then the lower. And I didn't see the overbite and the overjet. I mean, and what is the rationale of not changing the molar restorations? Because at the end of the case, I saw that you prepared a little bit more palatally the upper incisors.
Yeah. I understand your point. Actually, we took a maximum intercuspidation. The planification was made at the first part of the treatment. So we did first the wax up and also the dental design. So there we saw that we had enough space to deliver a correct overjet and overbite. So that's why we didn't make another rehabilitation position of the rehabilitation like you said. So the centriculation was the same as the MIP.
Okay.
The MIP.
Okay. Very good. Going to Paul. Paul was really very nice presentation. I have just one question. You used the one-time abutment, which is something that I agree very much. But you used the octa. And as I see the octa in the deep zone has a little bit wide angle. Can you elaborate? Are you a little bit concerned about this? That, in the deep zone, the first actually 1.5, 2 millimeters above the implants is going a little bit wide?
Yeah, if I can wish, I would have it a little bit smaller on this side, but it's it's much smaller than a multi-unit abutment for sure. That's not the reason, but I would wish it should be a little bit more smaller. I would totally agree to you, but my hands, it is the best option to go this way.
Do you know how much is the diameter of the octa?
Yeah, it's 3.8.
Okay.
Yeah. Yeah.
Okay, very good. So, but really very nice presentation, Paul. Congrats. So, Alvaro, amazing presentation. I saw in one publication 4 Alvaros. I mean, are you such a big family? So, my question to your case.
Yes.
What kind of zirconia did you use in the lower? This is the question number 1. And question
Yes.
number 2, maybe I missed that. How did you check the fit of the restoration in the mandible on those implants? I mean, did you go full digitally or did you do a verification jig? These are the 2 questions for you.
Yes. So the first question, I use a HT katana in this case. I think now HT is not produced anymore, but it was at that time. And then we use a low fusing porcelain from Naritake on the facial, the teeth, and the gum. And we went directly to the multi-unit, which nowadays we will use. We would change it, and we would use a titanium bar to connect the implants.
Exactly.
Yes. And
exactly. That was my point.
Yes, the interface back in 2015, we were going directly to the multi-units with the zirconia. We learned from our mistakes. We had some fracture and some erosion of the multi-units with directly zirconia. Plus, you don't have the feeling when you're screwing in. If you have zirconia is so stiff that you don't really know. So now we are not using that anymore. We have trouble finding high-strength zirconia because their companies are going more towards translucent zirconia, which weakens the strength.
Yeah.
And then the second question was the verification. Because we did back then a cast, we used a stone jig. We made a jig out of stone, type 4. We screw it all the way in, all the screws. Then we unscrew it. If it breaks, it's not possible. If it doesn't break, then you can go ahead and fabricate that.
So you went it the analog way.
Yes, yes, because we fabricated a master cast.
Okay.
Nowadays, if we are not going to fabricate a master cast, we go full digital.
Yeah.
Yes.
Very clear. Good. And going to the last one, Christian, really amazing. And I agree with David, very sexy presentation. And I want you to elaborate, and I also agree that we need ortho. All the prosthodontists, we need ortho. And you make our life always easier, much easier. Can you elaborate a little bit about the myofunction concept and the airway concept? I would like to hear a little bit more about it.
Okay, how many time do we have?
No, just be quick, because Roberto is watching us.
So, in short introduction to airway is that I already did in my older cases a lot of mistakes, which I recognize now. And that showed me that it is more important to treat or to think about airway first. And airway is, in ortho, airway is so important because we can improve the health of the patient so much more. We only have limited thoughts to aesthetic, to function, to perio and biomechanic, but it's so more important. And we have to think about why those symptoms we see happen. So when we have crowded teeth, when we have narrow arches, there is the reason, and the cause is often the myofunction, which is not happening first in the age of adults. It's starting from the early beginning of children. So when we look at airway conditions, we have always think about three things: structure, function, and behavior. Structure is what we can improve by treating the patients into the mouth, so bringing the narrow arch with different treatments, not only by aligners. We can expand it to the dome therapy, which I do in the practice, to expand the jaw. We have so much things to improve the structure, but then we have to think about the function. And the function is the reason why those things happen. Because when you have an anterior tongue tie or posterior tongue tie, the tongue is hanging down and all the muscles are pushing forces from the side. It's like having an intraoral orthodontic device. So the cause is so much more important because we do not want to have a relapse in that situation. And so we have to think about to take an anamnesis for the myofunction, to bring them to a myofunction therapist, and to watch for their behavior. So it's more, airway is much more than thinking of sleep or something like snoring. It's so much more. And what I learned in the last years is that I have to keep attention to that patient.
Okay, very good. So that was all, Roberto. So Giano, it's your turn.
Okay.
But I think for Giano, you should all of you, the four of you, should have periapical radiographs. I am sure you're gonna say this.
Yeah. I will be very, very short. Carla, very nice presentation.
Yeah.
And by the way, all of you have made a wonderful material and very clear, very easy to understand. Now, Carla, small question. Did you ever the X-ray and the oral X-rays before doing all the treatment? And also, did you make a perio chart? In other words, when you have to do surgery, you should have a very clear and easy to read perio chart. I didn't see it in your presentation.
Yeah, first of all, I referred the patient to perio, and he gave me the okay in order to start with the treatment, with the restorative treatment. And also, yeah, I did the periapical radiographies and all the sequence. I didn't place actually in the presentation. I'm sorry about that. Yeah. But of course, I made all the radiographies. Yeah.
Yeah. Well, this was just a consideration examining your presentation. Usually, whenever you do a surgery, to have a very nice set of X-rays and the periodontal chart is mandatory.
Yeah, for the surgery, we made a CBCT in order to have all the information.
Yeah, but sometimes you also need the intraoral X-rays to evaluate really nicely the distance. In your case, the distance between the bone crest and the CJ, and so.
I agree. Yeah. Thank you for your comment.
Well, no problem. Then, Paul, I wanted to ask you, the buccal bone was rebuilt by just placing the lamina, or did you also put some mixture of autologous bone and some bovine bone or something like that? Because
The first layer is, I understand completely. The first layer is the lamina on the buccal bone side. So this is rebuilding the buccal bone, and the space between the implant and the lamina was filled up with autogenous bone and MP3, a mixture. It's also Italian pork from the same company. Yeah.
Okay. And actually, do you feel confident to place an immediate implant when you have an extensive infection? Do you feel confident that it's the same instead of waiting for for a couple of months before going into the site?
No, I do not feel confident to place an implant. But I was very impressed when I looked at the literature that there is some literature out there where you can see if you have for sure not if you have a chronic infection and not an acute for sure. That's a different story. But if a small ones, I feel confident to go in. Yeah.
Okay. No, because sometimes in the literature you don't find all the informations, namely the percentage of success after a few years. And this is a very strange thing, because when we treat our patients, we want to have a long-term result and a long-term success. This is valid for a young dentist because he has to build his reputation, and the old dentist who has to maintain his reputation. So it's something which I would be very careful to decide. But nevertheless, your case is very nice, and you have done a fantastic job. Now,
thank you.
Christian, I am amazed by your treatment because really, and how you presented the case, fantastic. I learned a lot, and I congratulate with you. But nevertheless, at the end, you would appreciate a recession on the lower left side of the gingiva. There was an uneven recession on the cuspid and the premolars. And so the question is, would you consider to make a surgery before finalizing the case, when you see that the bone is very thin on the outside, and so maybe the recession can be limited by doing a surgery before?
That's a great question because there is literature behind that. The information where the bone is from around teeth and where the bone is in the remodeling process in the way we do ortho is not in the bone. The information from replacement bone comes from the PDL. And so what we have to think about is that we should protect the PDL as much as we can. So when we have a thin biotype, when we do bring teeth out of the envelope of the bone, and we need some remodeling processes that we do not lose buccal bone, we do have to do the connective tissue grafting before, or the thickening of the soft tissue. So in this situation, where we see what you saw is that we do not have to make an expansion or to upright lower teeth because they were not crowded or they did not have a negative Krontalk to the lingual side. So what we took the decision is to do it afterwards. So in situations where we need a lot of expansion, combining a lot of systems, when we need aligners, we need tabs, cellular expansion, we use SFOT techniques, there is a huge benefit when we do it before. So it was the right decision. I would do it again in that situation because I did not change the situation before and after. And when we want to have more expansion or we do it more uprighting, then there is a good idea to do it before.
Yeah. Well, I don't totally agree with this, because I think that when you move the risk for a recession, if you have a very thin buccal plate, we know it's very frequent. So I would say that when there is a minimum amount of attached gingiva, I would rather do it before the orthodontic treatment. Okay, and then Alvaro, I didn't get quite clearly when the lower bone was rebuilt.
It was at the beginning of the treatment, before we started the ortho. So we received the patient with already fibula graft, so part of the leg connecting the ramuses. We use, and that the patient had that plate. So we use as a starting point, and we built on top of that already grafted fibula.
Okay, but did you remove the
plate?
Yeah.
Yes, sir. We did.
Okay, and you removed the plate, and then immediately you did the regeneration of bone.
Yes, we because it was already stable for more than 6 months, the previous graft. So we were comfortable enough to remove the plate and build on top of that.
Okay, and you placed the implants at the same time?
No, so that's as I mentioned, a case we did several years ago. Nowadays, what we do an approach in a case like this is we place guided implants in the leg, then we remove the fibula graft and go directly to the mouth. But back then we rebuilt. We wait for more than 6 months. Then we remove the screws and then place the implants.
Okay. Anyway, congratulations to all of you, because I learned a lot, and so I enjoyed this meeting. Okay.
Thank you.
I would say that if
Thank
this
you.
is the beginning of this challenge, it's a very good beginning, because we have seen cases that were simply amazing, and it's just a very good motivation for the other participants to be excellent, because I don't know how much more excellent than this you can be. But unfortunately, we have to proclaim a winner. So now it comes the difficult time, because everybody is +10, but now the judges will have to vote.
Whoops.
So I will start from Dave, that is the good judge.
You want to start with
Dave, what is your score for Carla?
Well, I just want to make one comment. Paul, you mentioned about being confident, and you said not really, which I think was very honest. There was an American prosthodontist, some might remember, called Harold Chevelle. And when he did a full mouth rehab, he was also asked, how confident do you feel with placing 28 provisionals in one go? He says, I sleep like a baby. I wake up every hour crying and wet. So there's a lot of truism there. Okay, Roberto, which ones do you want me to give you first?
So first you have to vote for Carla.
Carla. For the quality of the images, I'll give you a 5.
You can just give me
Thank
the
you.
comprehensive vote, the full
Oh,
vote.
you want all 4?
You don't have to
add
vote.
it up?
Yeah, single. Yeah.
I need a calculator for this. I'm going to give 15 to Carla.
Thank you. Thank you so much.
You're welcome.
So now you have to vote for Paul.
Paul, I'm sorry, Paul. I'm only going to give you 19.
19.
Yep.
Okay.
Thank you so much.
Well, you don't come from Munich, do you?
Yeah,
Oh, take 10 points off. Bayern Munich is killing Manchester United. You're out of competition. Sorry.
So what's your score for Alvaro?
Alvaro Barca, well, they beat Manchester United in 2009, unfortunately. I don't know how we deduct that. Otherwise, for today's competition, I have to give you 19.
Okay.
Thank you.
Welcome.
And what about Christian?
Also from Munich? Oh, damn it. No, again, I feel like I'm repeating myself. I'm going to give you 19 for that.
Okay, perfect. Stavros, it's your turn.
Yes. So
What is your score for Carla?
for Carla, my score is 17.
Thank you. Thank you so much.
For Paul?
So for Paul, actually it's a tight 17 as well.
Thank you.
Okay, what about Alvaro?
Alvaro for me is a 20.
Okay, wonderful.
Thank you.
We have the first, congratulations, because you have the first full score. Okay, what about
And Christian, really very nice presentation. I give 18.
Okay, perfect. Okay, Giano, you're the last.
Okay. For Carla, I would say 15.
Okay,
Thank you. Thank you so much.
For Paul, 18.
okay.
Thank you.
And then I am very, very uncertain about Christian and Alvaro. I would say 20 for Christian, 19 for Alvaro. But I would say that they are even for me. they deserve the same. I was very impressed with your presentations.
I have to say that all deserve to win tonight, because I mean nobody was insufficient, or they were all excellent.
They were.
But somebody has to win. So I leave Giano to the judges to speak for a few minutes while I'm computing the scores, and then we'll come up with a winner. Okay.
Well, I think Stavros and Giano and I know each other so well from the European Academy, both on the stage, in the podium, and behind the scenes. Why are these four presenters not active in the European Academy?
That's really a good question.
Affiliate.
You're an affiliate, Christian? I'm on the affiliate committee. You're in trouble now because I need you to present the webinar. No, but the work was, and if I may say, I feel a little sorry that I scored Carla at only a 15, and in my eyes, it was just because for a restorative guy, it wasn't a very difficult case. It's a full mouth case you did, but it wasn't a difficult case, and I think that's where you lost out in the competition here, only because of that, nothing else. So, I hope you don't feel bad about that.
No, don't worry. It's okay.
No, I think you deserve an explanation, because the final result was gorgeous. There was no doubt about it. But I'd like Stavros. I mean, you're the young one in the academy. Giano and I, we're dinosaurs. No, we need to push people like Christian and Paul's team. I don't know who the third guy was, to get you involved. And Aldo, you're in Spain. You got Jaime around the corner. Okay, yes, you quoted your own papers there, so now we know that you published a little bit. But you guys deserve to be among our colleagues in the European Academy, I think.
Yeah, absolutely. I agree. I totally agree. We need these young people getting involved in leading the EID.
Yep, I think so.
I totally agree. All four of them deserve to be in the academy.
Yeah,
absolutely.
You understand that, guys?
Thank you. Yeah.
Thank you.
The third weekend of May in Porto, Portugal. You better be there. Good. I like that.
Okay,
Yes,
Okay.
Rebecca.
here we are with the scores. I have to say that the match eventually ended up 1-1 because Paul won the first game and Alvaro won the second game. But what is the difference maker is the points, and Carla plus Alvaro made 125 points, while Paul and Christian made 131 points. So the winner of this first game is Germany.
Congratulations.
Congratulations.
Congratulations to Germany, but also to Spain. It was a very, very fair contendant.
Thank you
And
so much.
I only hope to see you guys again because you really deserve. We will invite you to the Italian Academy of Aesthetic Dentistry for sure, because the international and the national crowd needs to see young people like you, motivated, excellent, and always striving for excellence. So I want to thank everybody for the participation. It was a pleasure. We were actually on time because if were not for the technical issues, we would have finished sharp on time. And I want to remind to the other people watching that this was the first game, but next Sunday we have another one at 12 o'clock noon Italian time. That will be another interesting game. Will be Japan versus South Africa. So two distant, very far away countries, and will be another intriguing, hopefully another fun and entertaining noon this time.
Yeah.
So, Robert, as the
Yes.
secretary of IFED, I want you to close the evening.
Yeah, thank you very much. So first, thank you to you all. And on behalf of the IFED, to the great players, all four, for the judges, which did their job voluntarily, and especially Roberto, for you, yeah, for your power, endorsement, everything that you built up this really highly interesting, sophisticating, marvelous talent. And we all are looking forward to next week. Sunday, where at 12 or noon Central European time will be the next game between South Africa and Japan.
Okay.
And I wish you all a very nice evening now. And it was really a great experience to see these absolutely incredible four presentations, especially as a maxillofacial surgeon, Alvaro. This is always what I want from my colleagues, that in our tumor patients, they have to do such a really great job you've done. Thank you.
Thank you.
Thank you.
Thank you all.
Bye.
Thank you.
Thank you.
Night. And thank you very much. Let's not forget to say
Congratulations.
thank you
Have a
to
good night.
Giacomo Armani and to Katalin for the support of Ulpia that well supported this evening. And despite the technical problems, we made it through. And I got a lot of I got a lag at a certain point because I was receiving so many messages on my phone. Everybody was watching and was watching quite properly, and everybody complimented for the quality of the transmission tonight. Good night, everybody.
Good night.
Bye-bye.
Good night.
Thank you.
Good night.
Thank you.